Hello everyone. Welcome to this episode of 4D 3.0, detailed discussion and dialogue for Indian diabetics. I am today's host, Dr. Saurabh Sharma. I am Associate Professor in Nephrology at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. And the topic for today's discussion is heart failure, CKD, and diabetes. Where do the guidelines converge? So it is a cardio kidney metabolic special webinar. And CKM is not just a clinical model, it is a team philosophy where heart, kidney, and metabolism they move together so that the patient doesn't have to walk three separate journeys. And today we have three powerhouse clinicians, all proudly representing Lucknow, the city of Tajib, Tehri, Kebabs, and gentle disagreements spoken with a smile. So I would like to welcome our speakers, panelists. First is Dr. Umesh Chandra Tripathi. Sir is Assistant Professor, Department of Cardiology at King George Medical University, Lucknow. Welcome, sir.
Hi, sir. Good evening.
Doctor. Good evening, sir. So next, Dr. Durgesh Pushkar, sir. Sir is a consultant nephrologist at Save Kidneys Clinic at Lucknow. Hello, sir.
Hey, Dr. Saurabh.
And the third is Dr. Nihit Kharkwal. Sir is consultant endocrinologist at Diabetes, Thyroid and Hormone Care Center, Lucknow. Welcome, sir.
Thank you. Thank you, sir.
So let's warm up with something fun before we get academic. And first question is for Dr. Umesh. So, sir, Lucknow is known for patience, politeness, and slow living. But cardiology, it is all about fast decisions, door to balloon time, crash calls, adrenaline. So how do you balance Lucknow's pehle aap culture with cardiology's right now urgency?
Sir, I think you have a very deep knowledge about Lucknow and its culture. And considering about cardiology, sir, when we are talking about cardiology, there is pehle aap thing also goes in cardiology as well. At King George Medical University, the emergency is very active of cardiology. It's not in entire country, hardly any centers are there with such a dynamic emergency. So with that, usually the patients are much aware about our center of King George Medical University, one of the top centers, high volume centers in India. So anything except for the private hospitals, if the faith is being placed, then most of the patients do actually place their faith on King George Medical University Department of Cardiology. So the volume is very high. We have to restrict the numbers. So after all those kebabs and other things which are the part of the staple diet, Dr. Nihit and Dr. Durgesh will better tell about that, about diet management. So that ultimately leads to coronary artery disease and they end up at King George Medical University.
So aptly said, sir. And now I will move to Dr. Durgesh, sir. Sir, as we know, as Dr. Umesh was also talking about, Lucknow is famous for biryani and also for nihari, and both are high on salt and protein. So as a nephrologist, do you secretly feel that Lucknow cuisine is your biggest referral generator? What do you think, sir?
So, talking about the dietary habits and the diet pattern of Indians, in North India especially. So in Lucknow, it is not that different. The salt intake and the people choosing to go outside and have meals and to the salt intake and the high cholesterol diet is no different as compared likewise the other metro cities. And yes, since Lucknow is the main referral center of East UP and right way extending up to Bihar, many patients apart from Lucknow, from other cities as well, we get referral for diabetics, CKDs, and hypertensive patients.
Yeah, you rightly said, sir. So just like I'm living in Delhi, so just like chole bhature of Delhi, you have biryani. So I think the cholesterol and salt intake is high in the North Indian population. It's likewise every other city, every other state capital. So I think it's right to say that hypertension and diabetes, they are increasing, and also the nephropathy cases are also increasing. So coming to Dr. Nihit, so sir, Lucknow ke sweets like the Malai Gilori, Makhan Malai, Rabdi, so they are pure love, but pure glucose too. So, what is the most creative excuse patients give you to avoid diabetes control?
Actually, sir, Lucknow people are very much foodie. And whenever
Yeah.
any patient from Lucknow or peripheral location comes to our OPD, they simply say that, sir, we are from Lucknow. If we don't eat street, what can we do now? So it is in their habit, it is in their lifestyle that they tend to use red meat, they tend to use food rich in cholesterol, rich in bad cholesterol actually, and they are very much, they have a very much sweet tooth actually. So because of that, um, the cases of diabetes, hyperglycemia, as well as cardiac complication and kidney complication are increasing day by day. And this we need to focus on. We need to teach or educate these people that they should avoid these diet and they should try to modify their diet and lifestyle.
So wonderfully explained, sir. So once in a week or month, this kind of food our body can tolerate. But if we have this dietary pattern in our daily habit, then it would definitely harm. So food culture and medicine in Lucknow are permanently interconnected. And let's go deeper into your journeys. So coming again to Umesh, sir. Sir, what pulled you into cardiology? Was it a thrill of emergency care, or just the fact that cardiologists never get a time to sit, so no weight gain issues? What do you say, sir?
So it's always the destiny that plays the part, sir.
Yeah.
Fortunately, my senior was Dr. Durgesh.
Oh,
So I think some seniors of mine and guidance has always been helpful, and that always paved the way. And plus the personal passion that one possesses. As boss went for nephrology, I went for cardiology, and me and boss also shared the same institute for DM. So that is so that is the only thing that your passion pulls you to that place. And so you also that same question I may ask to you as well, that what led you to become a nephrologist.
so I would like to answer this question after asking Dr. Durgesh too, but I would ask first to you that why you didn't opt for nephrology? Why Dr. Durgesh, sir, he didn't pull you towards nephrology instead of cardiology?
Sir, sir,
So so definitely the destiny itself plays its role. It's not like it's a mixture of our choices as well as the destiny as well as our peer what they have chosen. So it's mix of everything, not only our choice, but I think it's a kind of mix of uh, uh, our seniors, our juniors, our own choice, and what the family matters. So I will definitely answer your question, sir. But I would first ask Durgesh, sir. So Durgesh, sir, like we asked Umesh, sir, also. So nephrology, uh, if we say it can be emotionally heavy. It's like high risk patients, long follow ups, 3 a.m. emergencies. So, what was your turning point moment that made you choose nephrology with passion?
So going back to my MD days, my thesis guide, he used to push me about our unit used to follow kidney patients, and me myself will used to take dialysis rounds and used to see what is happening in dialysis. I used to train my juniors explaining the care of dialysis patients. And eventually, when I got the option to prepare for super speciality, then my inclination towards nephrology right from the MD, so I opted for nephrology. And there, during my training time, my one of my very senior consultant used to say that nephrology is nothing but it is glorified medicine. We see cardiology, we see endocrinology, we see infectious disease, we see neurology, we see all the branches. They somehow get involved in nephrology, be it critical care also. So it is we see all different kind of patient in nephrology, and that keeps you that also keeps you to look for what is update apart from nephrology, what updates are happening in cardiology, what updates are happening in endocrinology, what updates are happening in critical care medicine. So that was this driving force behind that I chose for nephrology.
So great, sir. So great choice, I would say, because I'm also in same field, and I now I would like to answer Umesh sir's question. So in why I chose nephrology is because of two reasons, I would say. First was during my MBBS days, I did my MBBS from SMS Medical College Jaipur. So during our surgery as well as medicine, like final year, uh, so our teachers, like in surgery, a urologist came and he taught us whole urology in six classes, so weekly classes. And in medicine also, when the renal medicine came, and in 4 or 5 classes they taught us very beautifully, like both urology as well as medicine, nephrology. So I was more inclined because of my teachers. And later, when I did my MD from RML hospital here in Delhi only. So there also we used to discuss ABG with our senior residents who are in nephrology. So that's how more inclination developed towards nephrology, and I also chose that. So coming to Nate sir, sir, endocrinology today is one of the most dynamic fields, from diabetes technology to obesity therapy, and now the cardio kidney metabolic care. So, what inspired you to choose this specialty, sir? The same question I asked both sirs.
It's actually the multiple factors responsible for choosing the endocrine as a field. First of all, there's a strong family history of diabetes in my family. So I thought, why not to choose that line so that I can treat my family members also. And second is one of my senior has chosen endocrine, and from him I learned a lot. And he used to tell me that being an endocrinologist, you can deal with many metabolic syndromes and many other things that we used to ignore, we used to forget about. So there are actually many other factors. Actually, my MD is from pediatrics line, so I think if you have done MD from pediatrics, so there are not many choices to do DM in adult line. I had only rheumatology and nephrology and endocrinology to choose from among these lines. So I choose this endocrine department.
Thank you for your beautiful journey in explaining about your beautiful journey in endocrinology, sir. So let's proceed to the CKM, to this topic, and cardio kidney metabolic care. And first, we would like to talk about the teamwork, the cardio kidney metabolic teamwork. So, first question is for you, Umesh sir. Like you told, you and Durgesh sir both are close friends, senior junior connection, and likewise, heart and kidney, they are also close friends. They are like siblings, and as the siblings fight, they also fight. Heart and kidney both fight in the ICU. So, what is the secret of reducing cardio nephro blame game and practicing teamwork? What is the secret in teamwork between cardio and renal? Like there may be a discussion on diuretics, on I would say on the dye, how much dye to give, the contrast-induced nephropathy. So there are so many things where there can be like a fight between the cardiologist and nephrologist. But so how to reduce this blame game and practice a teamwork? So you are the best person to tell, because you have a close friend who is a nephrologist.
So to throw light on this, let's start it when a patient comes to you in a OPD, and likewise, many a times a patient of heart failure with reduced ejection fraction or even with preserved ejection fraction, he's on multiple drugs on the four pillars, the guideline-directed medical therapy, which includes the ARNI or ACE inhibitors, SGLT2 inhibitors, beta blockers, as well as diuretic aldactone. So at that moment, uh, to reduce the number of pills that are nephrotoxic to the patient, or to calculate the EGFR right at that moment and prescribe drugs according to the EGFR levels. From that onwards, if the patient is of heart failure with reduced ejection fraction, to minimize the fluid intake, uh, regulating the potassium levels, if you have to take the patient for any angiography or any procedures, then as you said, that the limiting the amount of dye, seeing that the patient is not under hypotension, because if a patient is in a cardiogenic shock, and it further worsens the kidney functions, and if you take it to the procedures, the dye load again worsens it. If the patient is already dialysis dependent, and we have missed that, and we have taken the patient for angiography, and we haven't done a pre-procedure dialysis or a plan for a post-procedure dialysis, monitoring the urine output. Along with that, we sometimes use N-acetylcysteine also for to reducing the contrast-induced nephropathy, although the evidence is lacking for that, but still we do prefer it. So I think all these four modalities, if we consider, and even after post-procedure, we follow up the patient for the urine output, for the kidney function test, uh, and to maintain that the patient's mean arterial pressure is above 70 after procedure, or if the patient is under cardiogenic shock. So these all things are really helpful. And to consult, and one thing another, that you are a cardiologist, if I am a cardiologist and we know that my patient is having deranged kidney function, the kidneys are under pressure, so it's not at all bad to consult a nephrologist at that moment, and or right before it. If the patient is already a known diseased kidney patient, then you should always take the nephrologist into the loop, and then proceed forwards, which usually happens in our center most of the times.
So, sir, you have beautifully explained the CKM care. So, CKM care is a teamwork, and you have explained that. So, in CKM, the teamwork between the cardiologist, endocrinologist, nephrologist, that is all, and it is all about collaboration. So, coming to Durgesh, sir. So, sir, so we are talking about CKM. So, what is the one thing you wish that every clinician they should have understood about the kidney physiology before adjusting the diuretics? So, every patient who is a case of CKM, like cardio kidney or metabolic syndrome, so everyone would have been on diuretic or would be in on diuretic in a later stage also. But what is one thing that every physician before starting diuretic should know about the kidney physiology before adjusting the diuretics?
So in my practice, I start with the dietary advice, and I would expect that all the clinician, be it of any specialty, they should always start and counsel the patient about the salt intake, because whatever the driving factor for this what metabolic disorders, be it obesity, hypertension, or diabetes, or cardiac disorders, high salt intake is all linked with it. So the salt intake and the kidney physiology per se, the use of diuretic and their interaction with other drugs. Say suppose some patients are taking some drugs which have interactions with the diuretics. Say a patient is already on ACE inhibitors, ARBs, so starting them on diuretics, that would aggravate the renal injury that ACE inhibitors and ARBs might cause. And also some patients, the cardiologists prefer to put them on, prefer what's not to the correct word, but for the patient better symptoms in heart failure, they choose aldactone, which is a potassium sparing diuretic, and that drug should also be chosen carefully and started on dose, and dose should be adjusted, and patient should be counseled regarding the side effects or the chances of hyperkalemia, and to monitor potassium, monitor their urine output, and to also keep their potassium diet restricted. So main two things only: the salt intake and the drug to drug interaction, and also to counsel the patient. Like I very carefully, whenever I prescribe diuretic, I will write in bracket in Hindi that this medication is for your swelling, and as your swelling subside, or as you, because in we nephrologists, we clinically are only seeing up, we are only concerned with edema, but heart failure symptoms, if there is no edema, the patient might also have heart failure symptom as well. So my personal choice, I would write that this medication is for your swelling, and as soon your swelling subside, or as soon you start to feel any symptom, you better stop it or you better reduce it. And if a patient from cardiology OPD is being referred to my side, then also I will ask the patient that I am making these changes, and also I am telling you that these three drugs, whatever you're taking, be it a spironolactone or diuretic in any form, you go again with your meet again with your cardiologist, and you tell them that I have been advised by the nephrologist to adjust these doses accordingly. And some patient will come who are already taking this ARNIs they are taking, so they will also develop renal injury and hyperkalemia. We see in OPD patient coming from cardiology, they are taking ARNI, the dose already had been reduced. So the patient has been referred to our side for renal failure. The patient is also anxious that my creatinine has gone up. So that part is also should be a cohesive work, that cardiologist should also explain that this AKI is reversible. We have reduced the dose, and from our part also we should also counsel that this is not an issue of your anxiety. That drug has been reduced, and if it is not responding, then we can stop the drug also. But you better keep in touch with your cardiologist as well.
So thank you, sir. So you have to summarize about all the concepts that you have beautifully explained. One, we should have proper counseling of the patient, counseling the patient about the diuretics, why we are starting it, when to decrease the dose, when to increase the dose, when to stop it if it is not necessary. So, and second, we should always think about the drug-drug interactions, and so the two, or the concept of increasing the diuretic dose, or like adding another diuretic, so diuretic resistance. So the concept should be in our mind. And third is the salt restriction, that is very important. And I would say, like in a CKM prescription, the first thing we should write is salt restriction in all the patients. So that is the first thing we can prescribe. So thank you, sir. So coming to Dr. Nihit, sir. So sir, metabolic diseases, they sit silently for years. So what is your key message? Uh, so what is the key message every endocrinologist must give to prevent heart and kidney disasters early? So what is your message, sir?
See, initially, most of the clinician or endocrinologist mainly focused on hyperglycemia management. But at day by day, we learn that not only blood glucose level, but hyperlipidemia, hypertension, and smoking, all these factors are responsible for kidney complications or cardiac complications. Nowadays, obesity has become one of the major risk factors for cardiac or renal complications, along with other complications. So we need to educate clinicians as well as endocrinologists should focus on obesity treatment also, because uh, the name has also been changed from obesity to adiposity-related chronic disease. So we need to educate all the patients that not only blood glucose level should be controlled, but all other metabolic factors that comes in metabolic syndrome like hyperlipidemia, blood pressure control, and obesity needs to be focused on, needs to be treated as well, so that we can reduce cardiac, renal, and other complications that may be there if their blood glucose levels are uncontrolled, their blood pressure levels are in the upper range. So all these factors needs to be counseled and educate with the patients.
Thank you, sir. So you have explained that prevention is better than cure. So we should focus more on primordial, primary, and secondary prevention of cardio, kidney, metabolic syndromes, and of course diabetes, obesity, which is like comes under this umbrella only. So thank you, sir. So now one question for each of you on a lighter note. Like, so first question for Umesh, sir. So, sir, like initially we had discussed that there is a lot of fat in our diet, not only in Lucknow, like all over North India, I would say. In Delhi, I keep on scolding my patients for the this chola bhatura or parantha. So, and Modi ji has like recently he had mentioned in Mann Ki Baat to reduce the lipids, like the fat or the oil in our diet by 10%. And many people they are implementing that also in their regular diet, and it is very important to reduce the fat intake and the oil intake, oil in our preparations, in vegetable preparations, in parantha or any kind of fried food. So very important. So on the lighter note, so sir, which Lucknow dish is silently increasing your OPD load? Is it biryani, the tunde kebab, or nihari, or chicken korma? So what is the one dish you would say that it is increasing your OPD load? So it's just for the layman who is our audience. So for the patients or the layman, what would be your what would you say, sir?
Sir, actually, I'm a vegetarian. I don't know, but what most of the patients, they usually of coronary artery disease come are usually the one uh, who are taking a lot of intake of red meat that I have seen. So, and they have when we go for the angiography of them, it's a very extensive coronary artery disease. Then I asked them that whether you are a smoker, a diabetic, or something like that. But we find that on when we go into detailed history, it says that महीने में 4 बार लाल मांस खाते हैं. ऐसे they come up with that. So usually I have seen many Muslim patients are there who they have a regular intake of red meat. So
Yeah.
very severe coronary artery disease has been seen. So I think nihari is no, I don't know where does that it fits into the Lucknow dish, but
I think it
probably.
fits in the red meat only. Yeah. Yes, sir. Thank you, sir. Thank you for explaining that. So red meat we should limit. So everyone should be limiting the red meat, and because it increases the cardiac mobility. So well explained, sir. So coming to Durgesh, sir. So sir, on the lighter note also only, uh, if you could redesign the Lucknow food for kidney patients, what would be the renal friendly version of biryani?
So the friendlier was the friendliest version would be just you put spices, minimum amount of salt, and you better avoid red meat, and you better put a fish, and last option you put chicken, and also no sorry, fish, egg, and then chicken. And
Yes, sir.
I would also I'd like to add some points to the question which you asked to Dr. Tripathi
Yes,
regarding
yes, sir.
the the food we see in Lucknow. So it all starts with the whatever biryani is being made, whatever nihari is being made. It should be if we want to take, it should be from our kitchen only. If we
Yeah.
start choose things from our kitchen by cooking by ourselves, which is it is difficult, but if we start going towards that trend, that diet habit should be improved from our kitchen only. And unlike the West, the amount of ultra processed or processed food, it is not that much being eaten in India, but still the growing number of street food, the amount of time and amount of street food the Lucknow population is consuming, that is very alarming, because the refrying of food items, and the quality of oil they are using, the quality of food items they are using, the quality of salt, the amount of salt, that is very questionable. So it if the people start to take food from their kitchen, start cook use cook by yourself, you see, you take healthy, fresh items, you avoid ultra processed food, then it is good.
Thank you, sir. Yeah, very beautifully explained. So the main point is home cooked food. So you can eat anything, but should be home cooked. It is more healthy as compared to what we consume from the market. So because as you have explained, uh, it's been refried again and again, and there are so many saturated fats. It's loaded with saturated fats, and it's more harmful, very much more harmful. And if we start consuming home prepared, home cooked food, it's both beneficial because we can just redesign it as per our dietary habit. We can redesign it as per our disease, and there is no other alternative to that. Thank you, sir. So coming to Nate, sir. So, sir, on the lighter note only, I'm asking you this question. So, what is the most dangerous food item for the metabolic patients that you wish you could legally ban? Is it tunde kebab or the kulfi faluda?
Actually, it's crystal sugar. If one can one can advise me that you can stop one uh, dish or one food that you can stop at that point. So I will try to stop using crystal sugar because and one point that I want to add that people used to think that jaggery is useful, but it's not the case. And jaggery is also as harmful as crystal sugar for the diabetic patients, as well as honey. So most of the old age person used to take jaggery and they said that doctor साहब वो तो हम हमेशा खाते आ रहे हैं, ये तो मुंह मीठा करने वाली बातें हैं. So
Mm.
we should counsel, we should educate them that this should not be the case with a diabetic patient. And the red meat that or that Dr. Umesh, Dr. Rajesh also rightly said that red meat should clearly be avoided, and we can use egg, white egg, or uh, lean chicken or fish that were born to use take non-vegetarian items. And yes, kulfi follows is also harmful. If you want to prevent metabolic syndromes, then whatever actually the diet pattern of Lucknow people are, I don't think that is very good. And because of that, the metabolic syndrome is increasing day by day. So all these things, non-vegetarian, red meat, all these things should be avoided.
So, thank you very much, sir. So, you have beautifully explained that the sugars in the diet, they should be like it should be reduced to next to zero only, because and also it's not like the crystal sugar, the jaggery or the honey is better than the crystal sugar. All are having the same component. The glucose is there in each of them. So there is not like good sugar or bad sugar. So sugar itself is very harmful. So thank you, sir. So coming to our next question on CKM. So first question is for Dr. Umesh, sir. So, sir, like, what is one situation where you would strongly recommend initiating Findinone early? Like we have the four choices. These are the four pillars of guideline-directed medical therapy. You had talked about that in your previous question also. But out of them, everyone should be on RAS inhibitor. But out of GLP-1 RA and Findinone and SGLT2 inhibitor, what is your choice? One situation where you will choice and keep Findinone above SGLT2 inhibitor and GLP-1 RA, they should be started early.
As per the evidences that we have, only the fine arts HF trial has been shown some promising results. Arts HF also hasn't shown to be very promising about it. So only in patients of diabetic kidney disease with heart failure, along with metabolic syndrome or diabetes, we can go for that. So that is the only indication currently where Findinone has to be used, and that too after seeing that what is the EGFR of that patient. I think more than 30 it is advisable, and if it is even less than 30, we are not going to do that. And another thing that Findinone has really shown very promising results is that it causes least hyperkalemia as compared to other electron inhibitors, along with reduced sexual side effects of gynecomastia and other things. So that is the only condition there I may prefer. One thing good is that Finerenone along with SGLT2 inhibitors does reduces there is a reduced risk of hyperkalemia when we combine an SGLT2 inhibitors with Finerenone because of the osmotic diuresis as well as other reasons. So these are the only CKD with heart failure with diabetes is the only thing that I think Finerenone is currently advised.
Thank you, sir. So, Finerenone is an important drug which has just revolutionized the CKM care, and adding it over RAS inhibitor and keeping it above, like keeping it with the SGLT2 inhibitor, it's very beneficial for the patients of heart failure and with diabetes and in diabetic early stages of diabetic kidney disease, as you have mentioned, with the GFR of 25 to 30, more than that. So that's much beneficial nowadays, as per the this Fidello and Figario trial also. So thank you, sir. Coming to Durgesh, sir. So, sir, one clinical feature that immediately tells you that this patient must be on SGLT2 inhibitor today. So, what is one clinical feature? Like every patient CKM should be on RAS inhibitor, but you have seen a patient and you say that this should be on SGLT2 inhibitor.
Can you repeat the question?
Sir, I'm asking that most of the patients of CKM care, they are on RAS inhibitor. And we have the 4 pillars, out of which first pillar is RAS inhibitor, the second pillar is SGLT2 inhibitor, then Finerenone, then GLP-1RA. So what is one clinical feature in a patient? You see a patient in your OPD coming to you, and the patient is already taking RAS inhibitor, but you would say that this patient should also be on SGLT2 inhibitor. So what is one clinical feature that will alarm you?
So the diabetic patient who comes to us, be it with reduced EGFR or be there be a elevated albumin creatinine ratio. So I first check whether they are on whether they have been already put on ACE inhibitors or ARBs. Then we must see if the calculated GFR is what are the level of GFR at that time, and if the residual proteinuria is still there, if the proteinuria is still elevated, then I straight away start them on SGLT2 inhibitors. So the residual proteinuria, and if there is decline in kidney, if there is a declining EGFR, then it is better to start patient of diabetes or who are already on maximum or tolerated dose of ACE or ARBs. They should be started on SGLT2 inhibitors, so they can get the benefit of reduction of proteinuria and stabilization of the EGFR.
Thank you, sir. So the anti-proteinuric effect of SGLT2 inhibitor is far superior when combined with RAS inhibitor and Finerenone, and so beautifully explained, sir. So every patient who has proteinuria, any level of proteinuria, even non-proteinuric patients nowadays, there are so many trials which say that non-proteinuric patients also we should start SGLT2 inhibitor at early stage. So thank you, sir. Coming to Nihit, sir. So, sir, on the similar line, one patient who should definitely be offered a GLP-1RA early in a CKM scenario. So what would be one such case that should definitely be on GLP-1RA?
Patient is diabetic, obesity is there, and with any cardiac complication, and EGFR is decreasing, even on SGLT2 inhibitors and other nephroprotectors, then we should start them on GLP-1 receptor agonist. In fact, GLP-1 receptor agonist has a second best efficacious effect on blood sugar lowering. So, as an anti-diabetic medication, this is also a good treatment option, as well as to prevent cardiac complication and as a renal safe drug, this would be the choice. And in these type of patients, this patient is already obese or they have increase in weight.
Thank you, sir. So on nephrology perspective, I would say the FLOW trial, it has strengthened the role of GLP-1RA in our patients, diabetic nephropathy patients. So beautifully explained, sir. So coming to the last round of questions, which is on CKM therapies only. So first question for Umesh sir. So sir, in heart failure therapy, we often see that there is a drop in GFR, drop in blood pressure when we start the patients on uh, like uh, uh, like one patient only already on RAS inhibitor. Now we have to give Findinon, we have to give Arni, and we have to give SGLT2 inhibitor. Initially, there is a drop in blood pressure also, a drop in GFR also. So how do you counsel your young cardiologist friends, your just the trainings, or the young cardiologists to tolerate temporary wobbling of uh, these medications to show benefits? How do you counsel them? How do you train them, sir?
So first thing is that usually whenever these drugs are prescribed, the patient has a reduced ejection fraction of around 30%, 20% like that. So the baseline blood pressure is around 90, 100 kind of thing. And when we start ARNI or other BP lowering drugs, we generally say that until the patient is able to tolerate them, like if he has any dizziness complaint, very weakness, only then we are going to taper it or stop it, starting at the lowest possible dose. And even if the patient is able, for example, if we have started 50 milligram of sacubitril valsartan, and after 1 to 2 weeks of treatment, we find that there is hardly any increase in any derangement in the kidney functions, the BP remains stable, then we are going to increase it to 50, and hence it goes on. But usually it's not like that. 100 to 200, when we go to a dose of 100 to 200 milligram BD, the patient has a drop in blood pressure. He or she complains that there is weakness, there is dizziness on waking up, or there is postural hypotension. So that is the point when we know that now it's time that the patient not able to tolerate. So we have to go back to the dose earlier which he was using, and he was able to. He was very much compliant to that. Similarly with creatinine, as Dr. Durgesh sir said, that if the patient, the GFR should be monitored, the patient should be counseled that this is an irreversible change, this is an irreversible AKI, and as soon as the drug will be withdrawn or will be reduced, it is going, the kidney functions is going to revert back to normal. So, and if we talk about cutoff, there is no arbitrary cutoff that when to stop or when to move. But when the potassiums go beyond more than 6, then we have to stop it. If the creatinine, if the delta change in creatinine is more than 100%, then we have to stop it. If it goes beyond 3.5, then we have to stop it. If the creatinine goes more than 3.5. As well as when we talk about BP, if the baseline patient blood pressure of the patient was around 90 and it goes to 80, then up to 80, if the patient is asymptomatic, we have to do nothing. But the moment the patient, even at a blood pressure of 90, the patient is symptomatic, we have to modify the dose.
So thank you, sir. So you have explained that it's better to have a patient-centric care, and rather than going on the lab reports on the BP cutoff, rather than that, the patient it's more what the patient is telling you that is more important rather than the lab reports. So patient-centric care is very important while adjusting the doses or starting one of these pillars or earning.
In
So thank
that,
you, sir.
I like to add that there is a novel drug also, vericiguat, which we use for the phosphodiesterase 5
Yeah.
inhibitors. There has been trials of Victoria trial and Victor trial. So they usually it is an add-on drug. Even if a patient with decompensated heart failure with a BP, even in shock, we can use this drug if we have to improve the symptoms of the patient, and the patient is asymptomatic or the symptoms are not that worsening, then we can add another BP lowering drug. So everything is based in the current practice. It's on the basis of how the patient is able to tolerate it, how the kidneys are reacting to that, and the compliance.
Thank you, sir. So next question is for Durgesh, sir. So, sir, uh, like we have seen that most of our patients, we start on RAS inhibitor, we start it, and then we add Findinon. Then in heart failure patients, we have to add Ernie. So likewise, what Umesh sir was talking about, in these patients, what is how high the potassium, how high level of potassium would be safe, and what is your take upon the concept of permissive hyperkalemia, like how much hyperkalemia is permissible, and how, after what cutoff you would say that now we have to just come down, we have to just de-escalate the dose of RAS inhibitor or Findinon, we have to stop Findinon. We have the guidelines, but RAS inhibitor, when to stop it or when to decrease the dose. So what regarding that concept, sir?
So in my experience and in my practice, whenever I see patients who are taking ACE inhibitors or ARBs, and I have to, or they have been put on any mineralocorticoid receptor antagonist, be it spironolactone or be it finerenone. So first of all, I would ask the patient what I will see the patients what are his or her kidney function, how is her urine output, and has he or she been counseled about low potassium diet. And also, since if the kidney functions are if suppose eGFR is less than 60, so then obviously the excretory capacity of the kidneys is somewhat compromised. So the other route by which potassium get excreted is through our GI tract. So I also ask the patient whether they are having constipation or not, because if the GFR has declined and the patient is also having constipation, then chances of hyperkalemia are more increased. So diet counseling regarding this low potassium diet, ruling out constipation, and counseling the patient that if you are having any symptom, then you should immediately consult your cardiologist. And if you have a lab value of potassium more than 5.5, then it is better to omit the dose next day and you meet your treating physician. And regarding about target, I suppose it's like we see in dialysis patient, they usually tolerate potassium up to 5.5 without having any EC changes or without any complication. And also in cardiology practice, whatever we were taught or whatever we have seen, their cardiologists themselves, they are more scared of hypokalemia as compared to hyperkalemia, because hypokalemia is more associated with cardiac arrhythmias as compared to hyperkalemia. So they also try to keep the potassium of their patient in higher range, suppose 4.55, because less than 3.5 or 4, the chances of VT and VF are more increased. So again, this is totally on patient to patient. But my approach is diet. Then I rule out if a patient is having good bowel movement or not, and whether he has been counseled about the side effect of the hyperkalemia as a side effect of the drug he or she is taking.
Thank you, sir. So potassium also, it's all about the patient. It's the potassium level is also all about the patient, how much patient can tolerate. So that's what Durgesh sir was talking about. Thank you, sir. So coming to the last question for Nikhil sir. So sir, like we have talked about permissive hyperkalemia, we have talked about the permissive levels of blood pressure, GFR. So similarly, all of your patients, most of them are on SGLT2 inhibitors, and there is a rise in creatinine, and it's called permissive hypercreatinemia, that what we say. And we need to explain our patients that this initial rise is expected and it is protective rather than harmful. So how do you explain to your patients, sir? Because that would be a lesson for us also. We can also take that lesson and counsel our patients. So how should we counsel our patients?
So whenever I start my patients on SGLT2 inhibitors or ACE inhibitors or ARB, I will tell them that serum creatinine will or may be increased, and this should take a lot of liquid diet so that there will not be any hypovolemia that may increase their serum creatinine level. And I advise them to repeat their serum creatinine or KFT level after 4 to 6 weeks, and then will measure the serum creatinine level, how much it has been increased from the previous level. And most of the guidelines also recommend that we can give SGLT2 inhibitors initiate SGLT2 inhibitors up to 25. And if we have already started on any SGLT2 inhibitor, then we can continue to give this medication to our patients, and because of their nephroprotection, not their blood glucose lowering effect. And I used to tell my patient that this may increase their serum creatinine level, that no need to worry about that, and just keep on maintaining their hydration so that their they will not land on hypovolemia.
Thank you very much, sir. So very nicely explained. So that is end of today's discussion. It was very insightful, scientific, practical, and filled with Lucknow's grace. So if CKM becomes routine practice and not an exception, outcomes will change dramatically, and our patients will walk one integrated journey rather than three separate ones. So thank you, Umesh sir, Durgesh sir, and his sir, all from the land of Tehjeeb, Lucknow. And thanks to our audience for joining us. A good night and stay healthy. Thank you very much.
Thank you, Dr. Saru.
Good
Thank
night.
you, sir.
Thank you. Thank you.